Good evening, everyone. Thank you for joining us on this APCMC APSC joint webinar. This is the Asia Pacific Cardiometabolic Consortium and the Asian Pacific Society of Cardiology joint webinar. Today, we're talking about hot cardiometabolic topics from ESC 2025, and we typically hold this webinar after a major meeting such as the ESC. My name is KK Yo from the National Heart Centre, Singapore. And today we are honored to have three speakers. Dr. Kyung Hoon Cho from Korea, who is doing a sabbatical at Monash and Heart Centre in Melbourne. And he's going to be talking about Victorian difference study and inclisiran-based strategy versus standard of care. And then we're going to have Dr. Takamasa Iwai from Japan, who's going to be talking about the Essence TIMI 73B trial. And lastly, we're going to have Dr. Satoshi Honda from Japan talk about the Newton Cabbage CardioLink 5 study, which looks at evolocumab and saphenous vein graft patency. Now, just as a matter of housekeeping, each speaker will have 10 minutes, and then we will have 5 minutes for Q&A. So maybe with that quick introduction, I would like also to thank the Taiwan Heart Foundation for hosting this under the APSC Cloud platform. This is live. This will be a webinar that is broadcast. Maybe with that, I'd like to invite Dr. Cho, who will speak about the Victorian difference study on the role of inclisiran-based strategy versus standard of care. Dr. Cho, please.
Good evening, everyone. I'm Kyung-hoon Cho. I would like to talk about Victorian difference study, inclisiran-based strategy versus individualized optimized lipid-lowering therapy. Statins are the primary pharmacology treatment for dyslipidemia. However, many patients still fail to achieve their LDL cholesterol goals with statins alone, and response can vary due to factors like side effects, poor adherence, suboptimal therapy escalation, and statin intolerance. Statin-associated muscle symptoms are a primary reason for statin underutilization and discontinuation, affecting approximately 10% of patients. This significantly impacts medication adherence and LDL cholesterol achievement, leading to higher cardiovascular event rates. Inclisiran, genetic switching. A small interfering RNA acts on PCSK9 messenger RNA, leading to less PCSK9 protein. Less PCSK9 protein means more LDL cholesterol receptor on the hepatocyte surface. To clear out bad cholesterol, the real standout feature is the twice-yearly dosing after initial and 3 months doses. Through Orion 10 and 11 randomized controlled trials, it was demonstrated that inclisiran provides effective and sustained LDL cholesterol reduction with a favorable long-term safety profile. This study is the phase 4 double-blind placebo-controlled trial of an inclisiran-based strategy versus individualized optimized lipid-lowering therapy, IOLLT. If a patient were at very high or high cardiovascular risk and LDL cholesterol levels not at LDL cholesterol goals, such as 55 milligram per deciliter, for very high cardiovascular risk, and on stable statin dose for more than 30 days. They were randomized 1-to-1 to either inclisiran injection 300 milligram or placebo. Both groups received individualized optimized lipid-lowering therapy. The background therapy aimed to titrate lipid-lowering therapy if they did not have their LDL cholesterol goal, including rosuvastatin. Primary endpoint is the proportion of patients who achieved their LDL cholesterol goals at day 90s. Key secondary endpoint included percentage change from day 1 to day 360 in LDL cholesterol levels and proportion of patients with muscle-related adverse event. Other secondary endpoint included short-form brief pain inventory, the measuring pain intensity and interference with daily life. Let's look at the study population. 776 patients were enrolled from the 130 sites across 8 European countries. Mean age was 64 years. 70% were male. 97% were Caucasian. Mean LDL cholesterol was 91 milligram per deciliter. 92% were at very high cardiovascular risk. 41% diabetes mellitus, 85% hypertension, 40% had a previous myocardial infarction. Let's look at the prime endpoint, LDL cholesterol goal attainment by day 90s. The difference was stark. 85% inclusion group had LDL cholesterol goals, compared with 31% in the placebo group. It is nearly threefold increase in proportion achieving LDL cholesterol goals. It is statistically translated to 12 higher odds of obtaining LDL cholesterol goals in the inclusion group. In the right, you can see the subgroup analysis demonstrating consistently higher odds of obtaining LDL cholesterol goals in the inclusion group. Key secondary endpoint efficacy. There was much larger LDL cholesterol reduction in the inclusion group compared to placebo group. 59% versus 24%. The difference was about 35%. What's compelling is that the big drop was seen early by day 60s, and it stayed down consistently throughout the whole year. In the right loop, you can see the proportion of patients who achieved their LDL cholesterol goals at every 30 days. Key secondary endpoint safety. Inclusion group reported fewer muscle-related adverse events, 12% versus 90%, meaning 57% fewer patients in the inclusion group reported muscle-related adverse events. The mean dose of rosuvastatin was 13 mg per day in the inclusion group and 25 mg per day in the placebo group, meaning starting with inclisiran need less increase in the dose of statins. Inclisiran simplifies things. Secondary endpoint safety about quality of life. Inclisiran group experienced numerically fewer days with pain, 198 days versus 214 days, even though it did not reach statistical significance. Short-form brief pain inventory score was significantly numerically lower in the inclusion group compared to placebo group, even though it also did not reach statistical significance. What's intriguing was that the difference got wider across the study period. Even every metrics did not reach statistical significance. We could see the consistent result and the inclusion group was favored. Use of additional therapy on top of statins was significantly lower in the inclusion group compared to placebo group, meaning the inclusion simplifies things. Overall safety and tolerability looked good. Yeah, it was comparable between the two groups in terms of common side effect, serious adverse event. The number of deaths was very low and similar between the two groups. These are study limitations. The short duration of the study and 97% white and 70% of males may limit the generalizability of the outcomes. While inclusion placebo was double-blind, the background rosuvastatin was open-label. That could introduce some bias. This study did not evaluate the impact of inclusion on mortality or health economic outcomes. In conclusion, the Victorian difference study met its primary objective. An inclusion-based treatment strategy was superior to IOLLT in obtaining LDL cholesterol goals by the 90s. Also, it met both key secondary endpoints, a greater LDL cholesterol reduction and significantly fewer muscle-related adverse events with inclisiran treatment. And it observed a favorable trend regarding change in pain severity scores with inclisiran treatment. Inclisiran treatment had a comparable safety and tolerability profile to IOLLT. Using a study design closely aligned with clinical practice, the trial demonstrated that more patients achieve their LDL cholesterol goals early, and inclisiran is chosen as the first-line therapy after statins. This is the key highlight. This study is the largest inclisiran LDL cholesterol lowering study completed to date, and first study to include a patient-centric approach to evaluate the effect of an inclisiran-based treatment strategy versus individualized optimized lipid-lowering therapy on patient-reported outcomes, including key secondary endpoint of muscle-related adverse event and patient-related quality of life. This is the study close to real-world practice, as patients had individual therapy escalation until their guideline LDL cholesterol goals were met. Thank you very much.
Thank you, Dr. Cho, for a very clear presentation on the Victorian difference study. We have the speakers here and myself, in terms of discussion, and we have maybe about 5 minutes to discuss this paper. Could I trouble you to just leave your slides on screen as we may discuss them?
Okay.
Perhaps I could start with the first question while I invite Doctors Honda and EY to consider what they might want to ask. The first question is in the IOLLT arm, that is the individualized optimized arm. Can I check, and maybe you presented it, but I may have missed it. How many patients ended up using a PCSK9 inhibitor or inclisiran in this arm?
Yeah, out of 1,776 patients, 898 patients received inclisiran treatment.
No, I mean the individually optimized group, the IOLLT group. Did any patient end up requiring a PCSK9 inhibitor or inclisiran?
Yeah, IOLT group, as you can see, maybe five to maybe between 5 to 10% receive PCSK9.
And then maybe about 20% had bempedoic acid. Is that correct?
Yeah, right. Yeah.
Okay, thank you. I think that is important for the audience because you know we see from the earlier charts that a number of the curves sort of close together due to the individualized up titration of medical treatment. Would like to invite Dr. Honda, Dr. EY for your any questions. Maybe Dr. Honda first.
Yeah, Dr. Cho, thank you for great presentation. This is maybe a little bit apart from the presentation, but we all know that glucose lowering in patients with very high risk for cardiovascular events is very effective. But the current guideline recommend the target level of LDL cholesterol level less than 55. But in the daily clinical practice, the actual achievement rate of target cholesterol is very low. So in Japan, the recent paper reported that patient of ACS who achieve target level of LDL cholesterol is about 30%. So what is the achievement rate of target below target LDL cholesterol level in Korea? And do you often use PCSK9 inhibitor in your country for daily clinical practice?
Thank you very for a great comment. As you mentioned, in South Korea also, we had a very lower target achievement, even in patient at very high risk, such as acute myocardial infarction. I remember the recent registry data demonstrated maybe around 40 to 50 patient at very high risk achieved their LDL cholesterol goals. And in my practice, I would like to prescribe PCSK9 monoclonal antibody as much as possible. But there is some concerns about actually most the most concern is the cost, I think. So
So
I agree.
PCSK9 is very expensive drug, but does PCSK9 inhibitor covered by government insurance or patient have to pay for that?
If a patient were eligible to the reimbursement criteria, it is reimbursed. But if it is reimbursed, the cost is also not cheap. So we have to consider the cost of PCSK9 inhibitor when we prescribe it to the patient.
Thank you.
Thanks, Dr. Cho. Dr. EY, do you have any questions or comments?
Thank you for the great presentation. I was wondering that so that increased lung therapy enabled patients to achieve their LDL target goal. So, but do you really think that this early initiation of inclisiran or like PCSK9 inhibitor will translate into substantial reduction in cardiovascular events? Because the adverse event rate was really low and also similar among the two groups. So do you really think that this kind of strategy will benefit in our Asian population?
Thank you very much for great comment. I think we need more data regarding the efficacy of inclisiran on clinical outcomes, such as death and major cardiovascular event. But I think that the current evidence suggests that the early initiation of PCSK9 inhibitor, include inclisiran, may result in a lower instance of cardiovascular event. But I agree with your point of view that we need more data, and also in terms of the difference among PCSK9 inhibition strategy, I think inclisiran has the great advantage, such as the dosing. This is a real standout feature. Yes, inclisiran is administered twice yearly dosing after initial 2 doses at initial and 3 months dose. So in comparison to PCSK9 monoclonal antibody, I think inclisiran can have more sustainable and greater the LDL cholesterol reduction in a long time, I think.
Thank you very much.
Yeah, I think the standout feature is truly an important one. I would like to add that you know, the points raised about affordability as well as the clinical outcomes data would be important to inform our payers, whether it's an insurance company or the government, to support the use of this drug as a routine strategy. There is one other point I'd like to make, in addition to those points in which we have to wait for data. The other point is that in terms of the conduct of the study, how the questions for muscle aches were elicited, because patients, if you ask leading questions, patients may also highlight or may identify symptoms. In other words, if I ask, do you have muscle aches routinely, more likely than not, patients may, now that you mention it, could you, in just a very quick while, comment on how they ask the pain? If, in other words, if I every day ask you to do a pain diary, it is, it's a bit of a leading question, yeah?
Can I share?
Yes, please. Yes.
Shortly the appendix?
Yeah, go ahead.
Could you see? So in the SFBPI is a self-administered standard 15 items questionnaire. So questionnaire is composed of a pain diagram and 4 items about pain intensity: worst pain, least pain, average pain, and pain right now, and 2 items on pain relief treatment, and 1 item on pain interference, and 7 items: general activity, mood, working ability, normal work, relation with other people, sleep, and employment of life.
I think this will be important, and how we ask pain becomes relevant in real life. So I think, Dr. Cho, thanks very much. You have gone through the Victorian difference study, and I think the take-home message is that we probably still need more data, including cost effectiveness data, but it is very promising. And as you say, the key advantage is that this is a twice a year drug, and we look forward to additional studies being published and presented at various meetings. And some of us are involved in the Victorian Victorian 2 Prevent study, so that hopefully will be shared soon. So maybe with that, we can move on to the next presentation. I'd like to invite Dr. Takamasa EY from Japan to present on the Essence-TIMI 73B trial looking at olezarsen in patients with hypertriglyceridemia at high cardiovascular risk. Dr. EY, please.
Okay, let me share my slide.
Yes, we can see. If you could put to presentation mode.
Okay, is this okay?
Yes, thank you. Please go
Thank you
ahead.
very much. I'm pleased to present the results of APCMC 73B trial, a landmark phase 3 study evaluating orzalsen for moderate hypertriglyceridemia, which was presented at ESC 2025 on 30th of August by Brian Bergmark, and which was symptomatically published in the New England of Medicine just last month. So hypertriglyceridemia is remarkably common among our patients and is independently associated with increased cardiovascular risks. Elevated triglyceride levels are known to be associated with cardiovascular events. In patients with hypertriglyceridemia, the hazard ratio increases as triglyceride level rises. Although the majority of cases fall within the moderate range of 150 to 500 milligrams per deciliter, even in this range, higher triglyceride levels are associated with greater incidence of cardiovascular events. However, we have long struggled with the therapeutic gaps. Current triglyceride-lowering agent typically provides only modest triglyceride reduction of around 20%. Many of our high-risk patients with moderate hypertriglyceridemia remain above target despite of this therapy and could not show significant effectiveness. The rational role for targeting ApoC3 is compelling. ApoC3 acts as a metabolic brake on triglyceride clearance by inhibiting lipoprotein lipase and blocking hepatic uptake on triglyceride-rich remnants. Orzalsen is an N-acetylgalactosamine conjugated antisense oligonucleotide that specifically targets ApoC3 messenger RNA. This targeted approach allows for the precise reduction of ApoC3 production. Orzalsen is already approved in US for the familial chylomicronemia syndrome, where it has demonstrated both safety and efficacy in reducing severe hypertriglyceridemia and preventing acute pancreatitis. This study extends this evaluation to much larger population with moderate hypertriglyceridemia. So this study was phase 3 international double-blind placebo-controlled trial conducted at 160 sites across North America and Europe. The study enrolled patients with two categories. Those with moderate hypertriglycemia defined a triglyceride level between 150 to 500 and also had elevated cardiovascular risk. And those with severe hypertriglyceridemia of 500 milligrams per deciliter or higher. Patients were randomized in 1-to-3 ratio to either 50 milligram or 80 milligram of orzalsen cohorts. Then within each cohort, they were further randomized into 3-to-1 to receive monthly subcutaneous orzalsen or matching placebo. The primary endpoint focused on the percent change of triglyceride level from baseline to 6 months. And the secondary endpoint was changes in ApoC3, ApoB, non-HDL, and after 1 year. So this study included 1,478 subjects. 99.9% of the subjects received at least one dose of the study drugs. 30% had premature permanent drug discontinuation. 0.6% disease during the follow-up. 0.7% withdrawal. 0.5% had lost follow-up. For the population, because this was a randomized, double-blind randomized control trial, it was well balanced with median age of 64 years old and 40% women. 93% were white and 60% had diabetes. 96 of the patient was already receiving some kind of lipid-lowering therapy. Median triglyceride level was 238 mg per deciliter with hemoglobin A1C level of 6.2%. Now for the primary result, at 6 months, both doses of orexin achieved significant triglyceride reduction compared to the placebo. The 50 milligram dose reduced triglyceride level by 58.4%, and 80 milligram dose achieved 60.6% reduction. The triglyceride lowering in the key subgroups like older age, sex, diabetes, CKD, obesity, statin, or other lipid-lowering agent was not different between the two doses of 50 milligram or the 80 milligram groups. 85% of the 50 milligram group and 88.7% in the 80 milligram group achieved normal triglyceride level below 150 milligram per deciliter at both 6 months. And this efficacy was sustained through 12 months with dose maintenance. The lipid profile improvement extended well beyond triglyceride levels. As you can see, orexin reduced ApoC3 by 62 to 67%, non-HDL cholesterol by 22%, VLDL-C cholesterol by 57%, and remnant cholesterol by 66%, and ApoB by around 50%. And as for HDL cholesterol, it increased around 50%. And there was no significant change in LDL cholesterol. Regarding the safety, the overall incidence of serious adverse events were similar across the treatment groups. The most common treatment-related adverse events were injection site reaction, which was generally mild. Elevation of ALT, AST, linear dysfunction, platelet count reduction was similar among the placebo and treatment arms. As shown in the left side, among the 60% of patients who had diabetes at baseline, orexin treatment was associated with small increases of hemoglobin A1C level at 6 months and 12 months. As for the limitation, this trial primarily designed to assess orexin among patients with moderate hypertriglyceridemia rather than across the full range of triglyceride levels. 2 phase 3 trials are specifically evaluating orexin in patients with severe hypertriglyceridemia over 500 milligrams per deciliter. Efficacy and safety of orexin beyond 1 year of treatment was not assessed. And as for this, a longer-term open-label extension program among patients with a severe hypertriglyceridemia is underway. Importantly, it was not powered to assess cardiovascular outcomes, and this study was conducted primarily in white patients, around 93%. So orexin has demonstrated a markedly greater triglyceride-lowering effect comparing with current available agents like expendacetal omega-3 fatty acid or pemfibrate, and it achieved reduction of approximately 60% compared to around 20% of the other drugs. However, many potent triglyceride-lowering drugs are now under investigation, and it remains uncertain which agent will ultimately be adopted in the clinical practice. Importantly, the clinical gap we face is that impressive triglyceride reduction has not yet been proven to translate into cardiovascular benefits. Until we have dedicated cardiovascular outcome trial data, the clinical value of this therapy remains uncertain, even if the remarkable lipid lowering effects. So olzarsen achieved 60% triglyceride reduction in moderate hypertriglyceridemia patients and 70% reduction in remnant cholesterol, significant reduction in ApoB and non-HDL cholesterol with no major safety concerns. Thank you for your attention.
Thank you very much, Dr. Iwai. Very nice and clear presentation on olezarsen. Maybe I will ask if Dr. Cho would like to start off with any discussion points on the role of this new agent.
Yeah, thank you for great presentation. But as you know, there have not been the compelling the agent in terms of triglyceride lowering therapy that can reduce major cardiovascular event. I wonder whether there is any clue or evidence to suggest if this drug olezarsen can reduce the cardiovascular event compared with other drug studied.
Thank you for that great question. I think it's really important point. For my answer, I don't have exact data for cardiovascular outcome, but as I showed, the conventional triglyceride lowering therapy have only around 20% reduction of the reduction efficacy, but these drugs have around 60%, which is not which is really strong compared to the other drugs. So maybe we can get good clinical outcome, and so I'm really expecting on these drugs.
Thanks, Dr. Cho, Dr. Iwai. Dr. Honda, any comments?
Yeah, Dr. Iwai, thank you for a great presentation. So it's really I was surprised that this drug can achieve a dramatic reduction in triglyceride level compared to the previous drugs. But the most important thing is the reduction of cardiovascular outcome. So are there any ongoing study evaluating the impact of olezarsen on the reduction of cardiovascular outcome, or such plaque regulation like assessed by IBAS or OCT, something like that?
Yes, I think it's really it is also important point. Yes, in the presentation of the ESC, the presenter said that the outcome studies evaluating the cardiovascular outcome is ongoing in some drugs of these ApoC3 inhibitors or NGPLT inhibitors. And for the second question, I'm not really sure that whether there is a study currently evaluating the effect of these new drugs on atherosclerotic progression, like using cardiovascular imaging device. However, from our group, there is a previously published data showing that elevated ApoC3 level are associated with the progression of the lipid-rich plaque, which was assessed by using NIRS IBAS. So this result may suggest that this agent holds a really considerable potential for inhibiting the progression of the atherosclerotic changes.
Thank you. I look forward to the results of such studies.
I have one. Thanks, Satoshi. Dr. Iwai, I have a sort of a related question. Could you show the slide on the HbA1c? So I know that we don't have enough outcomes data, and this is a small group. Could you comment if this signal is sufficiently concerning regarding glycemic control? In your mind, because there is a statistically significant difference between the drug and those on placebo, do you think this is enough to make you worried?
Oh, thank you.
And related to this is, do you think that this is a class effect or specific to this drug? And do you see this signal in the other agents in this area?
Thank you very much for the important point. In this study, patient with diabetes, the Orzelsen group has slight increase in the hemoglobin A1C level, but I think it's really slight increases. And as for the because this drug has really strong effect on lowering the triglyceride level, I think this sub effect maybe is considerable. And as for the second question, I really I really haven't looked over the other drugs' effects to the glycemic control. So
I think,
yes.
yeah, no, I agree with you. I think that the data is not complete yet, and we don't know enough. But I'm glad that along with many of these other drugs in the cholesterol space, the regulators increasingly will require reassurance that outcomes are safe and that there are no off-target effects on either blood pressure or glycemic control. So this is, I think, an area that we would have to keep an eye on, especially in those who have pre-existing diabetes. So I'm glad that you showed this, and we would have, as a collective group, keep an eye on this. Maybe with that, it is a good time to go to something that is maybe less new, evolocumab. And I'd like to invite Dr. Satoshi Honda to speak to us about the Newton Cabbage Cardiolink 5 study, which looks at evolocumab and saphenous vein graft patency. Dr. Honda, please.
Thank you for the kind introduction. Good evening, everyone. I'm Satoshi Honda from National Cerebral and Cardiovascular Center in Japan. So today, I'm going to talk about the results of Newton CABG trial, which was presented at ESC, and the results were simultaneously published in The Lancet. So let me start. Oh, sorry. So as you know, CABG remains one of the most important revascularization strategies worldwide. So arteriographs such as internal mammary artery have excellent durability. However, saphenous vein graft or SVGs remains widely used. Unfortunately, SVG failure is common. About 20% occluded within the first year and 40% by 10 years. This failure is associated with recurrent ischemia and poor outcomes. So LD cholesterol is causal factor in atherosclerosis, and benefit of LDL cholesterol lowering in patients with atherosclerotic cardiovascular disease, including post-CABG patients, established for long-term cardiovascular events. However, the relationship between LDL cholesterol lowering and SVG patency is less clear. PCSK9 inhibitor provide very powerful LDL cholesterol reduction beyond what is achieved with statins. They also promote plaque regulation and stabilization and reduce cardiovascular events in high-risk patients. So the key question remained, could more intensive LDL cholesterol lowering with PCSK9 inhibitor prevent SVG failure? Therefore, in this trial, investigators aim to evaluate whether early initiation of intensive air cost lowering with evolocumab reduced SVG failure. So Newton CBG was an investigator-initiated, multi-center, double-blind, placebo-controlled trial. It was conducted at 23 sites in Canada, USA, Australia, and Hungary. Eligible patients were adults who undergo CBG with at least 2 saphenous vein grafts. They had to be randomized within 21 days of surgery, and all were required to be on moderate to high-intensity statin. Participants were randomly assigned in one-by-one fashion to receive evolocumab 140 mg every 2 weeks or matching placebo. The first injection was given within 33 days of randomization, and treatment continued for 24 months. The primary endpoint was a vein graft disease rate, and defined it at 24 months, defined it as at least 50% stenosis or occlusion on CT angiography or clinically indicated invasive angiography. Between 2019 and 2022, a total of 782 patients were randomized. 389 patients were randomized to evolocumab group, and 393 patients were randomized to placebo group. Importantly, 28% of patients in the evolocumab group and 31% in the placebo group were not included in the final analysis, mainly due to the loss of follow-up or no acquisition of CCTA for the evaluation of SVG. So nearly 30% of randomized patients was not included in the final analysis. So I'm sorry for busy slide, but this slide shows baseline patient characteristics. The median age was 66 years, and about 85% were men, and about 40% of patients had history of myocardial infarction. And nearly all patients were on statin and aspirin. About 1/3 of patients received dual antiplatelet therapy. The baseline LDL level was relatively low, about 1.85 millimole per liter, which is 17 milligram per deciliter in both groups. This slide shows procedure characteristics. So median number of grafts were 3 in both groups, and median number of SVG were 2 in both groups. And left internal mammary artery was used in more than about 95% of both groups. This slide shows LDL level during the follow-up. As expected, evolocumab achieved dramatic reduction in LDL level. At 3 months, LDL was reduced about 66%, and this effect was maintained. At 24 months, there was still about 48% placebo-adjusted reduction, and this corresponds to the absolute difference around 0.85% compared to the placebo group. This slide shows however, when it comes to the primary endpoint of vein graft patency, the results were disappointing. At 24 months, the vein graft disease rate was 21.7% in the evolocumab group versus 90.7% in the placebo group. And this difference was not statistically significant with a p-value of 0.44. Similarly, there was no difference in the total graft occlusion or in the proportion of patients with at least one occluded graft. This table shows a summary of outcomes. Overall, clinical events were infrequent and quite balanced between the two groups. The composite of cardiovascular death, stroke, myocardial infarction, or revascularization occurred 6% in the Evolocumab group and 5% in the placebo group. All-cause mortality was 2% in both groups. None of these endpoints showed any significant difference between the groups. So I'd like to summarize the main results of the Newton-Shaves trial. First, Evolocumab did not provide a significant benefit on the 24-month saphenous pain graft disease rate. The rate was 21.7% with Evolocumab versus 19.7% with placebo, and this was not statistically significant difference. Similarly, the secondary endpoints, including the proportion of completely occluded grafts and the number of patients with at least one occluded graft and MACE were not statistically significant. There was no significant difference between the groups. But there are some important insights. First, even in the contemporary era, about 20% of patients experience vein graft failure at 12 months. This clearly highlights the persistent unmet need for an effective strategy to maintain SVG patency. And second, Evolocumab substantially lowered LDL cholesterol level, but this did not translate it into improved SVG patency. This underscores the concept that early vein graft failure differ from native coronary artery disease. Therefore, further LDL cholesterol lowering may not be effective against these early processes. So, does this mean intensive LDL cholesterol lowering therapy are not useful after CVG? The answer is no, because these drugs remain essential for long-term secondary prevention of cardiovascular events after CVG, because the previous trials consistently show the benefit of intensive cholesterol lowering in patients with high cardiovascular risk, including post-CVG patients. But if our goal is to improve early SVG patency, we probably need different strategies. So the main mechanism of vein graft failure are quite different from native coronary atherosclerosis. So early SVG failure within 18 months is usually due to technical issue, competitive flow of native coronary artery, poor distal targets, intimal hyperplasia, thrombosis, and malartery remodeling. On the other hand, late failure beyond 2 years, which is resembles to native atherosclerosis. So therefore, early SVG patency may require alternative strategies, such as anti-thrombotic strategy, anti-remodeling, or anti-inflammatory approaches. So several limitations of this study should be noted. First, this study took place during the COVID-19 pandemic, so some CT follow-up data were missing. The second, the follow-up period was limited to 24 months, so long-term effect of Evolocumab on SVG remain unknown. Third, baseline LDL cholesterol level were already relatively low, around 1.8 mmol per liter. So the absolute reduction in LDL cholesterol level was modest. Finally, this trial was not powered for clinical events, and the number of female patients was relatively small. So in conclusions, Newton-CVG showed that intensive LDL cholesterol lowering with Evolocumab initiated within 3 weeks after CVG did not reduce the vein graft disease rate. So this makes clear that vein graft failure and native coronary cirrhosis are not the same process. Further research is needed to develop effective therapy that can prolong SVG durability. Thank you for your attention.
Thanks, Satoshi. A really nice presentation, and I'm really happy that we present data that is negative, and because a negative study is just as informative as a positive study, it helps us sharpen our understanding of pathophysiology, and in this case, why graft failure works, and that perhaps native coronary atherosclerosis is not the mechanism of action in for graft failure. I would like to invite Dr. EY and Dr. Cho, if you have any comments, please.
Okay, I have some questions. Do you this study evaluates the effect of the PCSK9 inhibitor in the surface graft? So, do you think will it be effective for the arterial graft, or as you mentioned that the late surface graft failure resembles with arterial occlusion, the mechanism of the occlusion of the artery graft. So will it be effective for the late surface graft failure, preventing the late surface graft failure?
Yes, thank you for important question. So regarding the artery graft failure, this manuscript reported that there's no significant difference in the artery graft failure between the two groups. But as you know, this trial was only 24 months follow-up. So basically, artery graft durability is much longer than that of SVG graft. So this trial was too short to assess the impact of evolocumab on the graft failure on artery graft or native coronary arteries. And again, this trial assessed the short-term SVG failure, but in the long-term follow-up, SVG could lead to the change in native coronary artery. So maybe extend the follow-up of this study, we may see some positive effect of evolocumab, but this trial was conducted during the COVID-19 pandemic, and they also mentioned that the extension trial was difficult to conduct.
Thank you very much.
Thanks, Dr. EY and Dr. Honda. Dr. Cho, any final comments before we as we reach the hour?
Yeah, thank you for a very interesting presentation. I would like to talk about discuss about this study's limitation regarding the generalizability. As you mentioned, the number of the study population, yes, is relatively small, I think, and I found out that the proportion of receiving AC inhibitor or ARB is just 40%. Yeah, and is there any other the limitation regarding the generalizability of this result?
Yes, thank you for the question. Yeah, as you mentioned, the use of AC inhibitor or ARB is not so high. Maybe as the proportion of patients who receive either of drugs, it does not reach to 50%. But in terms of the real world clinical practice, not all surgeons prescribe OMT for patients who underwent CABG. So this may be more close to real world clinical practice. But yeah, well, the results may be changed if we use higher rate of if we use more OMT for patients with CABG. Yeah.
Thank you very much, Dr. Cho and Dr. Honda. I think the only other comment I'd like to add is that the loss to follow up with the CT is an important limitation because it's incomplete. But be that as it may, the the data and the various subgroup analysis suggest that this is unlikely, although not we can't know for sure that this is a freak result. So I think maybe it's time to close the session. I'd like to summarize by saying that we heard presentations on two new drugs that are not yet in market. Inclisiran is in market, but not for the purpose as a strategy as described by Dr. Cho, and Dr. AY presented on olezarsen. And then lastly, we looked at a much more familiar drug, evolocumab, in the prevention of vein graft closure in patients with previous bypass surgery. I think these three presentations have been very informative in the realm of cardiometabolic diseases as a follow-through from ESC 2025. I'd like to thank everyone here who present, our presenters, as well as the discussion, and also for the Taiwan Heart Foundation for hosting this event. And with that, I'd like to close this APCMC APSC joint webinar. Thank you very much and have a good night.
Thank you. Good night.
Thank you very much. Have a good night.
Thank you very much.
Bye.